Okay, hey everybody, Dr. Rafich here from Vet Triage. It is Tuesday, January 7th, 2025, 2:35 p.m. Pacific Time. We are going through this Veterinary Surgery journal issue from October 2024. And we are talking about external skeletal fixation for the treatment of pelvic fractures in cats. This is by Dr. Fitzpatrick and others from Fitzpatrick Referrals in the UK. For those who don't know, Dr. Fitzpatrick I think he had a show. I don't know if it's still on or not, but it was a bionic vet, I think. And he's not even board certified, or at least when I knew him, he wasn't. Maybe he is now. But this guy is a monster. I mean, he is a legend in our field. He does these crazy surgeries. He does them well, and he publishes like an animal, and he lectures like crazy. He's great. And I met him one time at an elevator, in a conference, and just talked to him briefly, and he was very nice. And he basically sleeps at the clinic, and he does his operations like on overnights. That way he's not bothered. It's remarkable what this guy does and his dedication to the field. So kudos to Dr. Fitzpatrick. Noel, thank you for everything you do. Let's get into it. The objective is to report the technique and outcome for the repair of pelvic fractures in cats using external skeletal fixation. Retrospective, 125 cats. Results showed no intraoperative complications, no change in pelvic canal width on follow-up radiographs. Implant loosening was found on radiographs in 13% of cases. 8% of pins were palpably loose at the time of frame removal. The mean time to frame removal was 37 days. No long-term complications. Long-term mean mobility score was 95, and median lameness score was 0. So in the picture below, you can see very basically how we organize the different types, the terminology we use for external skeletal fixation. Just to give some background for those who don't know, there's three ways of fixing a fracture, which is a broken bone. External skeletal fixation, which is what you see here, it's ESF, and then internal skeletal fixation, where you place implants inside the body, and for the external, it's outside the body. The third possibility is external coaptation, which is just using a bandage or something like a splint or whatever, without either avoiding surgery or to complement surgery. So you can see on the right with Dr. Fitzpatrick's radiographs there from the journal, it's not as complex as you think, but it looks crazy on those radiographs. And so that's how we organize that's how we term the different types of it. So typically with cat pelvic fractures and dogs, but more so cats because they're so small and they usually they heal very well. Typically, pelvic fractures classically were either managed with conservative management, meaning analgesia, antibiotics, anti-inflammatories, and then keep them in a box until they heal. Wish them the best, or doing surgery that involves internal fixation or a combination of the two things. And it can involve other procedures too, like amputation, femoral head neck ostectomy, total hip replacement, etc., etc. So that's kind of the skinny on that. So introduction. Feline pelvic fractures are common and account for 22 to 32% of all feline fractures. The pelvis allows for the transfer of force from the pelvic limb to the axial skeleton. This, and just so you know, axial skeleton is versus appendicular. Appendicular are like the limbs, and axial is like the chest and pelvis, skull, things like that. This is often referred to as the weight-bearing axis. Conservative management is an option for ambulatory, non-painful animals. However, surgical stabilization provides analgesia and may be advocated for most fractures, especially if they involve the weight-bearing axis of the pelvis. In addition, pelvic canal collapse is present, which can lead to recurrent constipation, obstipation, and megacolon. For this reason, it has been suggested that all pelvic fractures resulting in pelvic canal narrowing should be stabilized surgically. Various surgical techniques for internal fixation have been reported for stabilization of sacroiliac fracture luxations, ilial fractures, acetabular fractures in dogs and cats. Concerns regarding impingement of the musculotendinous and neurovascular structures, pin loosening, infection, and problems related to patient compliance, and I would add owner compliance to that, precluded the widespread use of external fixation. Materials and methods. These cases were collected between 2001 and 2009. They were classified as unilateral or bilateral sacroiliac fracture luxation with or without concurrent fractures of the pubis or ischium, but with no evidence of ilial or acetabular fracture, Group 2 were fractures of the ilium with or without fractures of pubis and ischium, or sacroiliac luxation but with no evidence of acetabular fracture. And 3 were fractures of the acetabulum with or without pubis or ischium, sacroiliac luxation, or ilial fracture. Sacral fractures were classified as type 1 or type 2, and they were included in this study as these alar wing and sagittal fractures were considered clinically similar to sacroiliac luxation. Fractures of the ilium and acetabulum were subclassified into simple, which is 2-piece, mildly comminuted, which is 3 fragments, or highly comminuted, 4 fragments or more. Preoperative care for antibiotics, they received either cefuroxime or amoxicillin clavulanic acid. Patient preparation was pretty standard. Surgical technique. Group 1 was the sacroiliac fracture luxation group. He used Kirschner, Emer, or KE components. There's different systems of external skeletal fixers. They all have their pros and cons to them, but he used the KE, which might be the most commonly used one. He used negative profile, partially threaded pins, and used a 3-pin frame. So I'm going to show you a bunch of pictures. In this first picture, he used the pin anchor slide technique. So that's it there. There you go. So, and then here you have more pictures of the surgery, which again, you could pause the video and look into more detail regarding that. But he goes through a lot of the details, which we're gonna skip over here. It won't mean a lot to you without showing you the actual surgery itself. And here's some examples here. Pretty cool, fairly simple compared to the other ones he'll do later. The frame application for bilateral sacroiliac luxation involved 2 iliosacral pins. And then for group 2, which is the ilial fractures, he used namely the triangular frame and the quadrilateral frame. And so I'll show you that soon, but here's some more pictures there of some repairs. And then what he's talking about here, here you go, look at those. Yeah, it's outside the animal. You can see the triangular shape or the quad shape of those fixations, those constructs. All right, and then frame application for ilial fractures, use a triangular configuration, used for cases of isolated ilial body fractures or for ilial fractures with concurrent unilateral or bilateral sacroiliac luxation. And then pin placement, pin location was divided into 3 regions: iliosacral, ilial, including the cranial acetabulum, and ischial, which included the caudal acetabulum. Iliosacral pins, 1 or 2 iliosacral pins were placed across luxated or non-luxated sacroiliac joints. Ilial pins, they had 1 or 2 ilial pins were placed in each ilial region. And here's some more. This is a picture there, computer rendering of it, and then the intraoperative view below. Group 3, acetabular fractures. A triangular external skeletal fixation was used in cases of unilateral, simple, isolated fractures of the acetabulum. Here's some more pictures again. Most of this paper is pictures, which is awesome. Radiographs and intraoperative views of what he's doing. So for those who are interested in that, it's a pretty solid paper. He used a triangular external skeletal fixator consisting of 3 pins placed cranial and 2 pins placed caudal to the acetabular fracture and a single iliosacral pin contralaterally. The quadrilateral frame was used for cases with comminuted acetabular fractures or in cases with bilateral injury to the weight-bearing axis, regardless of fracture configuration. The quadrilateral setup consisted of bilateral iliosacral pins and bilateral ischial pins connected together in a quadrilateral construct. He also used drop pins, external skeletal fixation link assemblies, the KE clamps, and 3.2 millimeter connecting bars, which were Steinman pins. Aftercare involved hospitalization for 2 to 5 days. Dressings over the pin entry incisions were removed before discharge. They were managed with methadone or buprenorphine and oral meloxicam. They were discharged on meloxicam for 10 days minimum. The cage rest, 10 to 15 days of supervised daily activity in a small room during the 4 to 8 week postoperative period. Follow-up radiographs were scheduled at 6 weeks with a view to remove all implants at that time. The fixer was only removed if bridging osseous callus was noted on orthogonal projections. Orthogonal means 2 views, so usually a lateral and a VD or a lateral and a DV. DV is dorsal ventral view, VD is ventral dorsal view. For cases with solely sacroiliac luxation, radiographs follow-up and frame removal was advised after 4 weeks. Following removal of the fixation, a further week of cage rest, then 2 weeks of confinement, and then normal activity. So here are some more. Look at this repair. Look at that insanity. All that metal. It's great. And yeah, it's minimally invasive. It has all this metal with it, but all the complexity of the construct, but it's all minimally invasively done. He didn't mention that he did fluoroscopy, or unless I missed it, but typically when they do these things, they will use fluoroscopy. So it just goes to show you how good of a surgeon he is. He didn't even need that, you know. Okay, radiographic measurement. The percentage of measurement B, let's see. He defines measurement A and B. So it looks like the length of the fracture surface on one side of the sacral fracture was measured cranial to caudal on the ventral dorsal radiograph, which is measurement A. Measurement B is the length of the fracture surface in contact with the opposite side of the fracture that was measured. So the percentage of measurement B relative to A was calculated to determine the percent of fracture reduction. Fracture reduction was classified as anatomic, near anatomic, good, fair, or poor. For cases in group 3, fracture reduction was classified as anatomic, near anatomic, or non-anatomic as previously described. As previously reported, sacral index was used to measure the degree of pelvic canal narrowing for all the cases here. The mean sacral index was previously been reported as 0.97 for a normal feline pelvis and was thus used to estimate the pelvic canal diameter prior to injury by calculating the product of the craniosacral width and this sacral index. The degree of pelvic canal narrowing could then be calculated as a percentage of the original pelvic canal width. Outcome. Lameness was graded as 0 to 5. The presence of neurologic deficits was recorded. Long-term outcome was by owner postal questionnaire. Information about the cat's mobility, ability to run and jump, was graded on a visual analog scale from 1 to 100. 1 is poor, 100 is excellent. Owners were also asked to grade the presence of any lameness, 0 to 5. Information regarding presence of neurologic deficits like knuckling, being plantigrade, low tail carriage, ataxia, and any constipation. The results. Mean age of these cats was 33 months old. Mean weight was 4.2 kilograms. Concurrent musculoskeletal injuries, 14%. Pneumothorax, 9%. Fracture reduction in pelvic diameter. There was no meaningful change in the reduction of sacroiliac luxation between immediate postoperative at 92% and follow-up radiographs at 91%. There was no noteworthy change in the diameter of pelvic canal between immediate post-op and follow-up on all cases. Okay, now he's going to go into the group 1. So let me, the different groups. Let me look at the different groups, what they were. Okay, group 1, which is the sacroiliac fracture luxation, excluding the two type 2 sacral fractures, and one case with a femoral neck fracture. Mean time to removing the frame was 26 days. That's insanely fast. The mean time to frame removal for the other 3 cases was 42 days, which is still very fast. For group 2, and group 2 is the ilial fracture. For group 2, ilial fracture, mean time to removal was 42 days. And for group 3, which is the acetabular fracture, 44 days. Very fast, very fast. Radiographic union was confirmed in all fractures prior to removing the frame. Implant loosening was noted on follow-up radiographs in 0% of cases from group 1, which is the sacroiliac fracture luxation group, and then 18% from the ilial fracture group and 14% from the acetabular group. From the sacroiliac group, 6% pins were loose palpably, 9% from the ilial fracture group, and 9% from the acetabular. At the time of frame removal, median lameness for the ilial and the sacroiliac group was 0, and then for acetabular it was 1. There was no correlation between pin loosening and lameness. All neurologic deficits before surgery all had neurologic deficits before surgery associated with either sacral fractures or comminuted ilial fractures. There were no cases of constipation. So for long-term outcome for sacroiliac luxation group, median follow-up was 35 months, which is a very long time. Median mobility score 97. Median lameness 0. No problems with constipation and neurologic deficits. The ilial fracture group had a median follow-up of 32 months. The mean mobility score was 96. Lameness 0. No constipation. There were 2 cats that had neurologic deficits in that group. And then group 3 is acetabular, median follow-up 42 months, mean mobility score 89, median lameness was 1, no neuro, no constipation. Okay, discussion. Tolerance of the fixator was excellent. All fractures healed within 9 weeks. This healing occurred with a low complication rate, allowing a return to normal or near normal function on all the cats in the long term. The authors recommend at least 2, preferably 3, fixation pins placed in each major segment of the bone, cranial and caudal, to the fracture. However, single pins can be used to secure smaller fragments and facilitate the reduction, but that's not advised. Adhere to the far, near principle of external fixator application to ensure that the fracture fragments are adequately stabilized, as failure to do so may result in rotation around 2 fixation points if they are placed too close together. Far, near means, let's say this is the fracture site. You place your first implant far from the fracture site, the second implant far, and the next implants are near. And that's how you would do that. With external fixation, the fixation pins themselves are used to manipulate the bone fragments, reducing the risk of nerve injury, although care must be taken to ensure the nerve does not become entrapped in the fracture gap itself. No cases had revision surgery like femoral head neck ostectomy or hip replacement. And that is my only qualm with this paper. 2 qualms, I guess. One is we always want more cases, but 125 is great. And secondly, he didn't mention or comment on any hip degenerative joint disease or osteoarthritis that formed, either hip arthritis or even like lumbosacral, lower spine arthritis either. A benefit from external fixation when compared to plate and screw fixation is the ability to treat concurrent ipsilateral or contralateral pelvic injuries using the same apparatus and without repositioning the patient. Concurrent acetabular and iliobody fractures are relatively common, and treatment using plates and screws requires either 2 independent plates or a single plate contour to cross both fractures. And that's it. That's the paper. I think fantastic job as always, Dr. Fitzpatrick. Well done. Thanks to those who support the channel. Please subscribe and donate, hit like, all those things, and we'll see you guys again tomorrow. Take care.